Hi, welcome to QD Clinic. I'm Jack Cush with RheumNow. QD Clinic is brought to you by RNL23, March 18 and 19, 2023. Lately, our focus at RheumNow has been all about what rheums think. We want to hear what you think. We want to hear how you take the information from RheumNow.Live and apply it to your practice. We're going to hear from you during our extensive panel discussions throughout the meeting on that Saturday and that Sunday. We hope to see you there. Our QD case of today is weight loss in PsA. 35-year-old woman has psoriatic arthritis for about 14 years and maybe psoriasis for another 10 years on top of that. She has a history of being B27. She has low back pain, and she does have sacroiliitis. She has been diagnosed with psoriatic arthritis on the basis of an oligoarthritis, dactylitis, and in the past has had conjunctivitis. In the last 6 months, she's had a 40-pound weight loss, anorexia, belly pain, joint pain, fevers, chills, night sweats, and intermittent diarrhea. She can't take nonsteroidals. She's only taking etanercept, and it has gotten worse. More recently, she had a negative upper endoscopy and lower colonoscopy. She's not anemic. Well, she's mildly anemic. She platelet count's 517,000. Her CRP is markedly elevated at 5.9 milligrams per deciliter. That's 59 per liter. She's mildly hypoalbuminemic, has a high lipase, negative TB test, and she has an abdominal CT showing mesenteric adenopathy. She does have a positive stool guaiac. The question was, did she have maybe a lymphoma, a GI cancer, carcinoid? Could she have an infection? And again, the question is, what other tests would you do? Well, we did a lot of blood tests. Her immunoelectrophoresis and her SPEP were normal. She had no evidence of carcinoid on testing. She had normal vasoactive intestinal peptide and somatostatin levels. She had a repeat colonoscopy because she was admitted to the hospital. And this time around, it showed erosions, erythema of the terminal ileum compatible with ileitis. She had other evidence, other areas of patchy colitis and non-necrotizing granulomas that were negative for acid-fast bacilli. She was diagnosed with IBD, complicating her psoriatic disease. Now, the question on this case is there's a few things. One, could this be paradoxical psoriasis complicating her colitis? So let's just say she had Crohn's disease and she was getting a TNF inhibitor for her Crohn's disease. You know, when you use a TNF inhibitor, patients get psoriasis. And maybe you end up calling the Crohn's disease with paradoxical psoriasis, psoriatic arthritis, but obviously that's not the case here. But could you have the reverse? Could you have psoriasis and psoriatic arthritis that then gets IBD on the basis of her therapy? Well, not on the basis. There are a few case reports of TNF inhibitors causing colitis, so getting paradoxical colitis, but that's really ultra rare. There are way more cases of psoriasis and psoriatic arthritis treated with IL-17 inhibitors that then get colitis. And that seems to be a little bit more in patients who are B27 positive with sacroiliitis than if they did not have that. So does she have an overlap of spondyloarthritis between psoriatic arthritis and spondyloarthritis? I think she does. Is she not at higher risk of getting IBD? I think she is. But she's only being treated, basically ineffectively, with etanercept. So that's not the right therapy for her at this point for either her back disease, her other manifestations, extra spinal manifestations of spondyloarthritis, and also now for what appears to be Crohn's disease. How frequent is it that someone with psoriasis or psoriatic arthritis developed IBD? It's really quite uncommon. It's less than 5%. It's probably more like around 1.5% of all the patients. And, if you've got 30 million people with psoriasis or some crazy number like that, you'll see a fair number out there. But still, in my practice, I haven't seen many cases like this. And this is probably the only one I've seen like this. The treatment here, I think, is pretty straightforward. She does have active arthritis. She does have active colitis, and because of the colitis, you probably wouldn't want to give her an IL-17 inhibitor. You probably would want to give her a TNF inhibitor or the IL-12/23 inhibitor, ustekinumab, or possibly a JAK inhibitor, but JAK inhibitors only in high doses work in ulcerative colitis, don't work as well in Crohn's disease. So I would, again, have switched this lady to a higher dose of either infliximab, golimumab, certolizumab, or adalimumab, and manage her that way, and then work with the GI colleague to better manage her colitis and get her weight and her weight up and her inflammation back under control. That's it for this case of weight loss and PsA. Tune in for more QD Clinics.